Welcome to the Hospital Finance Podcast, your go-to source for information and insights that can help you stay ahead of the challenges impacting healthcare finance. And now, the host of the Hospital Finance Podcast, Michael Passanante.
Hi, this is Mike Passanante, and welcome back to the award-winning Hospital Finance Podcast. Healthcare interoperability is still a work in progress. Recently, the Office of the National Coordinator for Health Information Technology released new infoblocking rules intended to further facilitate the exchange of healthcare information. However, many providers still rely on legacy systems and technologies that will make it expensive and difficult for them to comply with these new rules. To explain what these new rules mean for providers and what they can do to optimize their capabilities while improving their bottom lines, I'm joined by Matt Michela, President and CEO of LifeImage. Matt, welcome to the show.
Thanks, Mike. Good to speak with you today.
Matt, we all know interoperability has been an issue for some time in healthcare. Can you give us an overview of the ONC's new info-blocking rules and why they are increasing the urgency around interoperability concerns?
Sure, absolutely. So, I guess I would say non-interoperability has actually been a great concern in healthcare for a long period of time, right? At least as long as I've been involved in healthcare for the last, for 30 years or so. And I think these challenges were recognized. That I give 30 seconds of history, right? In the end of the Obama administration, a bipartisan group of congressmen came together, right, to basically lay the foundation in place legislatively for dealing with data blocking and non-interoperability in healthcare, recognizing the real barriers to care and cost management that was driving across our healthcare system. And that was picked up in the Trump administration that continued in a bipartisan way to advance that legislation and move it into the regulatory process, which resulted here in the Office of the National Coordinator, right, and Don Rucker promulgating, after a long period of collecting feedback from the industry, a set of rules that really put in place new requirements for the industry to drive better transparency in data, better access to data. And it had, just a couple of components I think that are important here, right? One was it really leaned heavily into kind of the technology sector and establishing, right, what healthcare technology standards would need to be deployed in order to ensure that we're all, as vendors, right, that we have the ability to talk to each other and to work together. Because when we talk about healthcare standards, right, there's so many, or data standards, there's so many data standards in healthcare that, our problem is not that we don't have, any standard, it's that we have so many. And so every manufacturer, every software company, right, creates their kind of own mechanism of understanding and storing and sharing data. And if it doesn't match up with what another vendor has used, boom, it's not interoperable and you can't see it and access it. Kind of like in the old days, right, where, if you used a Mac, and you couldn't share your spreadsheets with somebody that used, IBM machine as an example. They became more interoperable. Healthcare is evolving into that space. So the ONC leaned into the technology standard and said, all right, we're going to tell everybody this is the standard you have to use. Do whatever you want inside your own systems, but ultimately you have to be able to expose data, right, using, FHIR as a category of a standard, right, and creating, what are called, APIs, which are standard ways of kind of understanding data and being able to see it and, access it. So that's a very, very big deal to work through that kind of technology kind of mechanism here so that industry knows going forward what they have to do most efficiently. The second was this kind of category of, okay, now that we're taking away industry's barrier or excuse around the technology side of the house, yes, they have to build into it. But we're not going to argue about healthcare standards or create new ways constantly of doing it at this stage. Let's put in place, or let's lean into behavior, right, of data blocking, right, for organizations that may, for their own purposes or their business model purposes or for lack of priority, right, they just don't give data to patients. here. And that ultimately, in healthcare, becoming more consumer-oriented is a good thing. In almost every other industry, it drives quality up and costs down. And so this meeting this needs of consumerism means you have to have access to data, and patients have to do that. So the ONC basically said, all right, here's your technology you have to use. They created, right, the first minimum, right, data set of data. So they basically said, okay, and these are the types of medical information you have to, be able to, provide, right? So patient history, demographics, lab information, basic imaging information, diagnosis, pathology, claimed costs, et cetera. It's not all of the types of healthcare data, and it's, pretty much kind of the low-hanging fruit that people know how to deal with most easily today. But it's a start. They said, this is your common data standard, and they said you have to share it with patients. And if you don't, there will be, compliance and regulatory consequences here, including, what could be very, very substantial fines. So industry, start working towards that and move forward. So that's what the ONC has principally, put in motion here. And it applies to providers, as we talk about here, as you mentioned here, but it also, applies to, healthcare insurers and payers that have their own set of requirements that ultimately means, as a subscriber or a member of a health plan, you'll be able to, relatively soon request, 5 years of your payment history from anything from their systems. And that should allow exposing the cost and what, plans have, paid for services here is going to be a big missing, it's going to fill a big missing gap we have for consumers to understand how to price shop and to understand the consequences of their healthcare decisions. Now, to the second point, Mike, and I know it was a relatively long answer, but the urgency around this, there's always been urgency. But particularly this year, I think the industry has come to understand pretty dramatically because of this pandemic, the real consequences of having non-interoperability, right, in healthcare here. When we look at COVID patients as an example, and CDC had done a study in the first wave of the pandemic of saying, all right, when patients show up and they're initially diagnosed with COVID, right, does that patient have their medical records available for the physician to then be able to determine what is their history, what are their particular issues of comorbidities or complications, so they can apply an appropriate treatment plan given their symptoms. And less than 6% of all patients that presented and were diagnosed with COVID in that early period of time had any access to their medical records at all. So with this disease in particular, that's so varied and so complicated and attacks so many systems in an area where physicians had to really apply right their greatest judgment for 94% of all patients showing up. The physicians had to go into that battle without the data they needed to be able to treat the patient. Right, that caused an untold number of patient harm here, of suboptimal care, and kind of an added cost. And so it became very dramatic, I think, to much of the delivery system and clinical side that this wasn't a theoretical conversation or an inconvenience, right? Not having access to this medical data, not for a small subset of patients, but for the majority of patients, is a real quality of care issue that ultimately has to be solved. And we haven't solved it yet, but I think throughout the course of this pandemic, it's become more and more apparent that this is not just required, but it is essential, and that we have to hurry up and get this done. And I think the ONC has set a fantastic table and foundation of building blocks to guide industry to get that done.
Great overview, Matt. And you mentioned in your answer a little bit about the fines and some other issues, repercussions, if you will, that can come up when a provider does not follow the ONC guidelines. Are you able to provide any additional detail on the repercussions of not following the new ONC rules?
Sure. I mean, some of these financial penalties, right, can be in the thousands or $10,000s of dollars, even upwards to $250,000 penalty for blocking data for individual patients. So when you think about, a practice that may have themselves, thousands of patients or tens of thousands of patients, right? A typical primary care physician, right? And again, that's not the typical kind of data we're talking about, but may have a panel of 2,000, 3,000, 4,000 patients across the board here. These fines mount up substantially, right? And the ONC to date has been relatively, and by to date, I mean this year, has been relatively careful and kind and gentle about many of these enforcement actions by delaying the implementation dates of that are required for healthcare technology companies to comply, right? Giving them some relief in the pandemic, but nevertheless, the penalties there are really substantial. And what will happen over time for on the provider side that we really have to be aware of, right, is in the past, some of your business practices blocked data. And you didn't even recognize, right? You're doing it in a relatively large bureaucracy or with some policies in place. The consequences and the fines for that, can be substantial. And before, where you might have a patient that is a little bit, inconvenienced or a little bit aggravated because they have to run around, or, under these rules, right? If a patient comes to you and says, "I want my data, and I'm using this technology platform, this app, as an example, to collect my data. I'm not coming into the office, transfer it to me." Many healthcare organizations historically would say, "No, we're not doing that." Right? Our internal policy is, no, you have to come in the office, you have to sign consent forms, you have to travel around. We have, we'll get it to you in a month or 2 months. Those are all violations now, right? Providers have to supply that data. They have to provide it digitally in the means that the patient has requested it, assuming that they're capable of doing that here. And they have relatively stringent time constraints, which had been set at about 30 days, but are moving right down to even 2 weeks or 15 days of a turnaround time. And I think what we're going to find as an industry, right, and on the provider side, is that patients are going to get more vocal. Patients are going to they're being educated, and they're going to recognize that they have rights in this regard. And they're going to be the ones starting to notify the ONC and the compliance folks and CMS and Health and Human Services that their providers are not complying here. And this sense of patients reporting really does increase, right, the risk. We're moving past the place where patients are kind of historically complacent and listen to their provider directions, and much more into a consumer-oriented world where they expect, responses quickly, immediately, efficiently, and will start to complain if they don't get it in larger numbers. And so, as a provider, we got to pay attention to this, right? Because it's very easy to get behind, and the next thing you know, you've got 3 patient complaints that get researched and find out that it's been your normal business practice and affected 15,000 patients, and all of a sudden you're in a huge financial problem here. So I have to be very careful with that.
Matt, I want to pivot a little bit and talk about a specific area of data exchange when we talk about maybe getting behind. Given the need to streamline access to this information, it's actually surprising that CD-ROMs are still used as widely as they are in healthcare to exchange data and images between providers and patients. Why is there still a reliance on this older technology?
Great question, Mike. And when you look at the transfer, the exchange, the sharing of medical imaging here in the country, despite the fact that the technology has existed, right, to digitize it and effect a secure encrypted transfer without any degradation of the data, and that's existed for almost a decade and a half. LifeImage invented the category. It's not a technology question in that it's not mature. It is. It really is a couple of other drivers, right? One is just the inherent delay in adoption of new technology by the delivery system, right? And folks continue to talk about the fact that we have fax machines out there. The next horrible example beyond fax machines, right, is unfortunately CDs here for imaging. So as a matter of practice, that's what they always did. That's what they continue to do. That's what their internal policies are set up to do. in many regards, is what people's full-time jobs are to do. And so, evolving out of that, practice requires, diligence and, attention. And sometimes it just hasn't occurred, quite frankly, across the industry. The second kind of, I think, factor here, again, is a tolerance in the industry for non-interoperability. CD-ROMs, right, for imaging is, classic example of non-interoperability. Not only are there significant delays in acquiring them and producing them, and we're inconveniencing patients from running around, or we're mailing them around, which is not as secure as it needs to be. Generally somewhere around 12-ish% of all medical imaging that's actually put onto a CD can't actually be read by the physician, the group, the practice manager, et cetera, who has to take it and upload it and make it work, right? Because the viewer isn't quite right. The standard isn't quite right. The disc ultimately is corrupted. It's a, 3D tomo that's too big to fit on a CD-ROM or even a DVD, right, as the technology has evolved. So even all of this effort to produce them and move it around on physical media still has, material problems when you can push a button and transfer it, right? But as an institution, right, what we find is they look and they say, I'm a typical, large scale hospital, and I've got lots of things going on. I've got lots of departments. Every department may be operating independently. That's another barrier, because we work with organizations that are incredibly sophisticated and digitizing their imaging and moving it around, but they still have pockets of departments and practices and geographies, right, where they've never implemented that technology, and so they're relying on CDs. So just the nature of the organization itself and how unified they are with their technology can also be a barrier to affecting some of this change and dumping the disk and digitizing what you need to do. It's maturing, but nevertheless still another challenge. Another component is typically in some of these organizations you'll have the part of the company that's responsible, part of a delivery system that's responsible for the image management, right, tends to be in what they call the PACS administrator function. And they've got a budget, and they have to pay for hardware and software and all of the rest of these kind of issues here. And if they have an image exchange partner, they're paying a vendor, and they're paying that vendor a certain amount of money. And the more you digitize, the more you pay that vendor. So there is this unfortunate perverse dynamic in some parts of the industry where the cost of CD management production sits out in the clinical areas, sits out in the department, it's dispersed, right? That cardiology may have a full-time person doing it, and appointments in oncology get delayed a week because they don't have the images they need to schedule an appointment. It doesn't affect my budget if I'm running the IT department in a PACS administration, right? But if I digitize it all, my budget goes up, and I may not get credit for that or appreciated. So part of this issue, unfortunately, in some parts of the industry, are that the cost of this of these CDs, both in delays in scheduling and effects on revenue and impacts to patient care, is dispersed, but the actual cost from a technology point of view isn't, and it's not aligned. And that misalignment then takes more time, right, for organizations to get their hands around it, understand it, and then push forward. Another kind of issue here that has contributed to it is a bit of lack of priority, because again, since the accountability and the consequence of managing CDs, it might not be mine, right, in the technology world here, but what is the ability to implement a brand new EHR across the system, or problems that I have in revenue cycle management and technology there, or billing issues I have. And so those issues tend to be bigger, much more impactful, sometimes hundreds of millions of dollars to solve, and they get the priority and the attention, where the interoperability around imaging, might fall 5th on your priority list, or 10th or 15th. And so year over year, it gets slightly less attention. It takes a lot more effort, right, to get people to react to it across the board. Having said that, so even like with our company today, we still have, 13,000 facilities in the U.S., who are digital and do transfer DICOM, and we're doing that, every month for 12 to 15 million patients that are being referred around within the United States. So it's being addressed at scale, but nevertheless, still, more than 50% of all imaging is still at CD. So there's a long way we still have to go for those reasons.
Matt, what are some compliant alternatives to CD-ROMs at this point?
So, quite frankly, there's a number of companies that operate in the space that offer software solutions that will connect directly to your PACS. They're very sophisticated, either integrations into your existing EHR, right, which we do on all the major EHRs, so you don't have to modify your workflow, or lots of other flexibility to basically, work off your workstation to search on a patient, acquire, imaging, push a button, and transfer it to almost anywhere in the world that you want it to securely. Those solutions exist. It really is a question of, just deploying them. Again, it's the priority of the organization. What we found, right, at least at our company here during this year, was especially early on when the pandemic was starting and was in its first surge, since LifeImage is so heavily penetrated in the large institutions and academic and tertiary care centers and in all of the major metropolitan areas in the country. That's where COVID hit. And so our customers were materially affected right away out of the first wave. And they recognized very early on that they really did need to be more interoperable for imaging. And we received a massive amount of requests to connect into new delivery systems, new sites, temporary field hospitals, et cetera. And in the course of 3 to 4 months, we connected, virtually, I think it was somewhere in the range of, 500 brand new hospitals right on the LifeImage network. Again, because of this awareness of we have to solve this problem. And so, in that period of time, right, we were just, working really, really hard to advance that. That's slowed down a bit now towards the second half of the year, which is kind of interesting. And I think is, more reflective of, I'm advancing onto other types of, treatment with both COVID as well as, returning to elective procedures here.
Matt, I suppose you could see where there would be some low-hanging fruit around operational efficiencies over CD-ROMs. Are there any cost savings for, hospitals that want to move away from CD-ROMs and into this more digital world?
Sure. It's material cost savings here. It's not, on a margin basis, right? It's important, right? Depending upon which type of institution you are, management of a single CD-ROM is going to cost you somewhere between $8 and $16, right? With the larger facilities, with the more efficient workflows, with some of the centralized tools of managing, CDs, we'll get it down to $8. Smaller facilities, mid-sized facilities, more rural facilities, et cetera, folks that are managing CDs on a part-time basis along the way, it could easily be $16, right, as CD. And that's the handling, the purchase, the burning, the equipment, the staff time. So in comparison, if you digitize it, right, not only do you get, you're basically, lowering that cost, right, at scale for large institutions, for well below, right, $1 here. And that's a massive, right, marginal savings across the board when you talk about large scale institutions here. In smaller institutions that are looking for every single dollar, right, in this terrible healthcare experience, right, it's got a very clear ROI, if they can pay attention to it. So it's a very inefficient or a very efficient scale way to digitize, get rid of those CDs here and make that work. So the issue, of course, is, in pure raw, so while this might be an 8-to-1 or a 16-to-1 savings, ROI on it, in raw dollars, right, it dwarfs, right, what problem you're going to have if your billing system in Epic goes down, or Cerner, because I'm not picking on Epic, on any of the EHRs during implementation. So that's one of the reasons organizations, get confused about this. But real cost savings, and that's before, Mike, we talk about the impact of patients, right, and care, which is, quite frankly, it's unmeasured here. But, we have a number of institutions, right, that that deal with oncology, as an example, and in many cases, right, they won't schedule, right, a meeting with a patient. They won't take an outside referral for an initial diagnosis or for a second opinion unless they already have in hand those patients' medical records. And we've got a number of institutions that want 5 years of history with imaging. And so as a patient, you may spend 30 days collecting that information before you can actually have an oncologist review it and discuss it with you. And there are cancers that cannot wait 30 days. There are cancers that progress aggressively in that 30-day period of waiting, right, causes real issues, causes significant cost, in the background. Here, that's not met. This, $18 to $16 a physical CD doesn't account for that patient care opportunity or the added cost of the healthcare system because a disease has progressed faster in that period of time. We have 150 stroke centers that we support in the United States, level 1 trauma treatment centers. And, the use case here is a patient presents in the community and, and gets imaged. And then the patient, needs to be transferred right to a level 1 trauma center for treatment. Well, when you're talking about, stroke, again, whether it's a bleed or a clot, right? Every minute are millions of brain cells. And so for Life Image, right, we have the ability to, take that image from the community level, transfer it to the trauma center so that the care team there can see it, analyze it, understand it while the patient is still either inpatient at the community center or, frankly, en route an ambulance or by helicopter, and to transfer that data to that center so that the physicians can determine what an appropriate treatment is so the patient can be treated before they even roll in the door, right? Whereas, unfortunately, there's still many, many facilities in the country where the patient will be imaged and they slap that CD-ROM and tape it to their chest and then roll them in the door. And then the care team is the first time to see that data. They could spend 12 to 30 minutes in extracting the data, trying to understand it, take a look at it, and treat. In that kind of, in that kind of clinical condition, right, is the difference in many cases between whether patients live or die. It's the difference between whether a health plan has to pay $1 million or $2 million or $5 million for additional rehab that could have otherwise been avoided. So the acceleration of data, especially around imaging, which is so important now in almost every significant medical issue that we have today, is, fundamentally, right, a clinical care quality of care issue, right? And, and it has a 8 to 16 to 1 ROI if you do it. So, this is why, we come to work every day, because we recognize that this isn't just a software issue. This is really this is a quality care issue for millions of patients every single, day here. And continue to advocate for this digitization and interoperability, right, is an application, not just a professional experience.
Great stuff, Matt. If someone wanted to find out more about you or Life Image, where can they go?
Thank you for asking. So you can go to lifeimage.com, which will take you to our website that will explain the services, the products, the markets, et cetera, we're at. Gives you the ability to ask additional questions or talk with anybody internally at the organization that is required, not just the salespeople, but technical folks or whatever. So I would direct you there, as a start.
Matt Michela, thanks for coming by the Hospital Finance Podcast today.
Thank you, Mike. Appreciate it.
This concludes today's episode of the Hospital Finance Podcast. For show notes and additional resources to help you protect and enhance revenue at your hospital, visit Bessler.com/podcasts. The Hospital Finance Podcast is a production of Bessler. Smart about revenue, tenacious about results.